Bismillahirrahmanirrahim. Today we are going to start a discussion with the blood-brain barrier. Before that, we had discussed the meninges and stuff like that. And before continuing the session, I would like to thank Dr. Moin Ahmed for giving his marvelous book to me for doing these read with me sessions. Now let's start with the blood-brain barrier. So, blood-brain barrier prevents the circulating blood substances, for example, the bacteria and drugs, from reaching the cerebrospinal fluid and central nervous system. It is formed by three structures, that is tight junctions, the basement membrane and the astrocyte foot processes. The tight junctions between the non-fenestrated capillary endothelial cells, then the basement membrane and the astrocyte foot processes. These three components together constitute the blood-brain barrier. Which substances to pass? The glucose and amino acid cross slowly by carrier mediated transport mechanism. The non-polar lipid soluble substances cross rapidly via diffusion. So even the glucose and amino acid are transported via carrier mediated transport system. A few subspecialized brain regions with fenestrated capillaries and no blood-brain barrier. These areas are very important because you must know that there are certain areas in the brain where the blood-brain barrier is either broken or not present at all. So these areas are as follows. They allow the molecules in blood to affect the brain function. Number one is area postrema, that is also called as the chemo trigger zone. It is the caudal end of the fourth ventricle in the medulla. Chemo agent affect this area and send signal to the vomiting center in the medulla, vomiting after the chemotherapy. The OVLT is the organum vasculosum of the lamina terminalis. It does the osmotic sensing and it is present on the anterior wall of the third ventricle. Then we have median eminence of hypothalamus. It releases the hormones into the vascular system to the pituitary. It releases the hormones into the vascular system to the pituitary and it allows the hypothalamus to regulate the pituitary. Posterior pituitary gland releases oxytocin and ADH secretion and it does not contain the blood-brain barrier. Then pineal gland, which produces melatonin, also lacks the blood-brain barrier. Now here you can see different areas which do not have the blood-brain barrier. Number one, in this diagram you can see that we have a subcortical organ. Then here you can see the pineal gland does not have the blood-brain barrier. Then OVLT, posterior pituitary, that is also called the neurohypophysis. Then we have the median eminence, area postrema, that is present on the floor of the fourth ventricle. And then we have, okay, all these are the areas which do not have the blood-brain barrier. Now here you can see what the blood-brain barrier actually is. Most capillaries in the body are fenestrated, which means that there is a water-lined pore through which the substances can be filtered out of the capillary or can enter into the capillary, but most of the time it is filtering out. So this is the pore passage. Then transport mechanism for lipid soluble substances is through the walls of the capillary, and for the non soluble substances is through the water lined pore. And then there are cells which are forming the wall of the capillary, which are called as the endothelial cells. In the blood brain barrier, firstly the capillaries are non fenestrated. Here you can see that there is a pore over here, there the pore is present, but in this picture there is no pore which is present between the endothelial cells. Endothelial cells are joined together, thus they are non fenestrated. Secondly, there is carrier mediated transport of glucose and amino acid to the brain substance. Then lipid soluble substances, they can cross freely because of the lipid permeability, and we know that the cell membranes are made up of lipid bilayers. So lipid soluble substances can dissolve into the membrane and can pass through easily, for example carbon dioxide gas and stuff like that. Then we have tight junctions and there are no pores and astrocyte foot processes. So in this picture you can see, if I could change the color, I'm sorry, yeah. So firstly there are tight junctions, like these are the tight junctions which are present in the tight junctions which are present over here, like these are the tight junctions which are present between the endothelial cells. Secondly, there is a basement membrane on which these endothelial cells are resting. So these are the two layers of the blood-brain barrier. The first one is the tight junction between the endothelial cells. Second is the basement membrane, and thirdly we have these foot processes. These are the foot processes formed by the astrocytes. These foot processes. So these three layers constitute the blood-brain barrier that is present in the throughout the brain substance, throughout the central nervous system. Then moving on to the next page, infarction or the neoplasm destroy the endothelial cell tight junctions. If there is any infarction or neoplasm, that will destroy the endothelial cell tight junctions, and that will result in the vasogenic edema, because if the integrity of the blood brain barrier is lost, excessive amount of fluid will start entering the brain, and that will result in vasogenic edema. Other notable barriers include the blood testis barrier, which is similar to that of the blood brain barrier, and the maternal fetal blood barrier of the placenta. Then we have the tight junctions. The Uworld point about the tight junction is that Tight junctions between the non-fenestrated capillary and endothelial cells prevent the paracellular passage of the fluid and solutes. The barrier only permits the passage of substances from the blood to the brain via transcellular movement. So, suppose this is a cell and then it is also another cell. The paracellular movement is between these two cells, while the transcellular movement is across these two cells. If we are talking about tight junctions, so these two cells are, I'm sorry, these two cells are lying so close to each other that there is no chance of paracellular transport. So only transport that can be done is across the cell, that is also called the transcellular movement. Now let's talk about the across the endothelial plasma membrane, which is limited by diffusion or carrier mediated transport. The transcellular movement of the dopamine is limited by the molecule's low lipid solubility. Okay, so that is why the dopamine cannot cross the blood-brain barrier. Suppose in the patient of Parkinsonism, if we are supposed to give him dopamine, we give him L-dopa, because L-dopa can cross the blood-brain barrier while the dopamine in itself cannot, because of the low lipid solubility of the molecule of dopamine. Then the next point is about the vomiting center. The vomiting center is an area that does not contain blood-brain barrier. Okay, the vomiting center is coordinated by the nucleus tractus solitarius in the medulla, which receives information from the chemotrigger zone located in the area postrema in the fourth ventricle. So, vomiting center is coordinated by nucleus tractus solitarius, and it receives the information from the chemotrigger zone. And chemotrigger zone within the area postrema does not contain the blood-brain barrier, so it can detect the presence of any chemical in the blood that can be that can induce vomiting or stuff like that. GI tract, vagus nerve, and vestibular system and CNS. So the nucleus tractus solitarius, which is coordinating the vomiting center, is receiving information from number one, chemoreceptor zone, number two, GIT, then number three is from the vestibular system, and number four from the central nervous system. You must remember this thing. It kind of gets confusing at times. The chemotrigger zone, vomiting center, the chemotrigger zone and adjacent vomiting center nuclei receive input from five major receptors. The first one is the muscarinic receptor, then dopamine receptors, histamine receptor, dopamine D2 receptor, muscarinic M1 receptors. For histamine it is H1 receptor, serotonin 5-HT3 receptors, and neurokinin NK1 receptor. 5-HT3, D2 and NK1 antagonists are used to treat the chemotherapy induced vomiting. Okay. Then M1 and H1 antagonists are used to treat motion sickness and hyperemesis gravidarum. We'll talk about these anti-emetics in the GAT sessions as well as maybe in the neuro sessions. But for the serotonin antagonists, we have ondansetron. The D2 antagonists include metoclopramide, and NK1 antagonists include aprepitant. M1 antagonists include scopolamine, and H1 antagonists include, I guess, I don't remember the names of that. I actually don't remember the names of it. Okay, so now let's move forward. So here they have summarized the vomiting centers. So okay, so let's start. Pain, anticipatory, for example, smell, pain or anticipatory smell, sight, fear. They will stimulate the higher cortical centers, and those higher cortical centers will stimulate the vomiting center via vomiting center. Okay, then chemotherapy and anesthetics and opioids, they will stimulate the chemotrigger zone and area postrema, dopamine, acetylcholine, serotonin, histamine, blah 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 blah, and neurokinin, and that chemotrigger zone will ultimately stimulate the vomiting center. Thirdly, the thirdly, the motion sickness will stimulate the nucleus of tractus solitarius via acetylcholine, histamine, dopamine, serotonin, neurokinin, and that nucleus tractus solitarius is again going to stimulate the vomiting center. The stimuli from the pharynx and stomach will go to the visceral afferent fibers on the vagus nerve. They will stimulate the chemotrigger zone, and that will also go to the vomiting center, and all of these triggering of the vomiting center will ultimately lead to the vomiting reflex. Then we have the next point, that is about the sleep physiology. It is very high yield. Sleep is regulated by the circadian rhythm, which is driven by the suprachiasmatic nucleus of the hypothalamus. Circadian rhythm controls the nocturnal release of ACTH, prolactin, and melatonin and norepinephrine. So these are the four neurotransmitters: acetylcholine, prolactin, melatonin, and norepinephrine, which are responsible for control of the sleep or circadian rhythm. The suprachiasmatic nucleus will release norepinephrine on the pineal gland, that will cause the release of melatonin. Suprachiasmatic nucleus is regulated by the environment, for example, light. So the release of melatonin by the pineal gland is responsible for stimulation of the for maintenance of the circadian rhythm, and the release of melatonin is regulated by norepinephrine coming from the suprachiasmatic nucleus. Uworld point about melatonin is supplementation is recommended for the treatment of insomnia associated with a jet lag by Hamilton. Two stages, rapid eye movement and non-rapid eye movement. So we can distribute the sleep into REM sleep, rapid eye movement sleep and non-rapid eye movement sleep. Alcohol, benzodiazepine and barbiturates are associated with a decrease in REM sleep and delta wave sleep. Norepinephrine also decreases the REM sleep. Benzodiazepines are useful for night terrors and sleepwalking by decreasing the N3 and REM sleep. Okay, so benzodiazepine decrease the N3 sleep because N3 sleep is the part of the sleep in which we have night terrors, because it was something like that we wee and flee in N3 and stuff like that. And REM sleep is also decreased by the benzodiazepines. So now here you can see that stages of sleep and description. When we are awake, like we are lying, we have lied on the bed, but still we are awake with eyes open. So description is alert, active, and active mental concentration will be there. The waves in this part of the sleep is beta waves. They have the highest frequency and lowest amplitude. So waves with the highest frequency and lowest amplitude are seen when we have open eyes. Awake with the closed eyes have alpha waves. So beta waves when we are awake with open eyes, and as soon as we close the eyes, the waves become alpha waves. Then we have after closing the eyes, we go directly into non-REM sleep. That is stage N1, N2, and N3. So that is subdivided into stages N1, N2, and N3. So N2 is the longest part of the sleep, 45% of it. Then the rest is distributed evenly. So stage N1, it is light sleep. N1, it contains theta waves. The stage N2, that is deeper sleep with bruxism, teeth grinding occurs. So sleep spindles and K complexes are present in the N2 part of the sleep, and there will be tooth grinding. So remember, like tooth grinding for N2. Stage N3, that is 25% of the sleep. It is the deepest non-REM sleep, slow wave sleep, and it is when sleepwalking, the night terrors, and bedwetting occurs. So delta, lowest frequency and highest amplitude. So delta wave sleep is seen, and that is the lowest frequency and highest amplitude of the sleep. Then comes the REM sleep. So basically there is a cyclical pattern, if the donor or not. But if we have a REM sleep, we have bouts of REM sleep every 90 minutes, and then after 90 minutes we go back to the non-REM sleep N1, N2, N3, then we come back to the REM sleep and stuff like that. So in REM sleep we have a loss of motor tone, increased vein oxygen use, and increased variable pulse and blood pressure, increased acetylcholine. When dreaming, nightmares and penile lateral tumescence occurs, that is basically erection, may, may serve memory processing function. Depression increases the total REM sleep but decreases the REM latency. Okay, so REM sleep increases, but the latency period between the REM, like from one REM to the next REM period, the latency period is the period from one REM sleep to the next REM sleep, and that is decreased in depression. Then we have extraocular movement. I will check this out. I will check that REM latency. I'm not sure about that. Okay, so extraocular movements due to the activity of the PPRF, parapontine reticular formation, paramedian pontine reticular formation, conjugate gaze center. It occurs every 90 minutes and duration increases throughout the night. So in this we see the beta waves. At nights, bats drinks the blood. So beta waves were also seen when we were awakened with eyes open, and the same waves are seen in the REM sleep. So the mnemonic is bats drink blood at night. Bats drink blood. So initially there are beta waves with eye open, then as soon as we close the eye, they become alpha waves. Then T is for the theta waves in the N1 sleep, then S is for the sleep spindles and K complexes, that is in the N2 sleep, and in N3 we have the delta waves, and ultimately in the REM sleep we come back to the beta waves. So remember these waves. And now let's go to the cerebral cortex region. So these regions, which are also called as homunculus, they are very important. Now let's see the diagram and then we'll go later on. So in the frontal lobe we have frontal eye field, which are also called as the push buttons of the eyes. Like if they are stimulated, the eyes will be pushed to the opposite side and vice versa. But we'll see these conjugate gazes when we do the eye physiology. Then we have the prefrontal association cortex. There is Broca's area. This is very important and high yield point, that this area is called as the Broca's area, and this area is called as the Wernicke's area, right? So we have the Broca's area, and here we have the Wernicke's area, and this area is very high yield. This is called as the primary auditory cortex. So remember these things. Then there is a fissure that is called as the Sylvian fissure, that divides the frontoparietal lobe from the temporal lobe. That basically is the demarcation of the temporal lobe. This area, like this area, is the temporal lobe. And okay, then we have the limbic association area is present over here, and then we have the primary visual cortex that is present here, and the somatosensory cortex is over there, and central sulcus. So basically, the areas that you are never supposed to forget are, I'm sorry, they are the frontal eye field, the Wernicke's area, the Broca's area, the primary auditory cortex, and the primary visual cortex. Never ever forget them. And if you want to score highest marks in step 1 exam, so remember, the primary motor area is anterior to the central sulcus, and primary somatosensory area is posterior to the somatosensory cortex. Posterior to the central sulcus. Now let's move on to the frontal lobe. Frontal lobe is responsible for the motor function, that is by initiation of the movements, planning movements, thinking, feeling, imagining, and making decisions. The key areas are motor cortex, frontal eye field, Broca's speech area, and prefrontal cortex. So motor cortex and prefrontal cortex along with the Broca's speech area and frontal eye field are present in the frontal lobe. Remember this thing. Primary motor area. The primary motor area site is the floor of central sulcus and posterior part of precentral gyrus. The posterior part of the precentral gyrus, this primary, we are talking about this area, like this area. So we are talking about this area. So the site is the floor of the central sulcus. The primary motor area is present at the floor of the central sulcus and posterior part of the precentral gyrus. The function is initiation of the voluntary motor activity of the opposite side of the body through the pyramidal tracts. In this area, the body is represented upside down. So we will see the homunculus just after a few minutes. But the body is represented upside down means that the legs are present, the area for the lower limb is present on the top. Then as we come down, we have the area for the maybe hands and trunk, and then here we have the face area and stuff like that. So area, the body is presented upside down. Then moving forward to the next point, that is about the lesions of the primary motor area. So lesions can be irritative, which stimulate the area, or they may be destructive, that destroy or inhibit the area. So when there is irritative lesions, contralateral motor Jacksonian fits will be seen. There are convulsions involving the muscle of one side of the body. The fit has a focal onset either in the thumb, angle of mouth, or big toe, depending on whether the irritative lesion starts in the lower or upper part of the motor area. The fit spreads to the in a march course, that is thumb, arm, shoulder, and trunk, and then to the lower limb, and that is why it is called as a Jacksonian march as well. If there are destructive lesions, so there will be contralateral paralysis, usually affecting one limb, that is called as a monoplegia. Premotor area, that is area 6, that is also present in the frontal lobe, and that is depicted over here, premotor area. Okay, so this is premotor cortex, that is just anterior to the primary motor cortex. So it is this area. It is a site anterior to the precentral gyrus. Function: it partly supplies the pyramidal tract. It gives extra pyramidal fibers. This area inhibits the muscle tone and deep reflexes on the opposite side of the body. So they are repeatedly talking about pyramidal tracts. Let me pause a minute and tell you what the pyramidal tracts are. If I draw a cerebral cortex like this, and this, something like that. So these are cerebral cortex. Then we have the midbrain, the pons, and medulla. So remember that the pyramidal tracts are the motor fibers. These are the motor fibers that are originating in the cortex and coming all the way down. They decussate at the pyramids of the medulla. That is why they are called as the pyramidal tracts. So if I draw them over here, so they look something like that. Like these are originating from here. They are coming all the way from the posterior limb of the internal capsule and stuff like that. And when they reach the medulla, most of them, like 90% of them decussate under the pyramids, and then and then they move downward like this, and same goes like this, and over here like this. So these are called as the pyramidal tracts. So pyramidal tracts, if I draw a brain over here, like the lateral view of the brain, like this, like this. And so if this is the brain and this is the central sulcus, so if this is the central sulcus, just anterior to the central sulcus is the primary motor area. Then anterior to that we have the premotor area, and posterior to that, okay, let me change the colors of this. If I draw a central sulcus like this, so in the central sulcus, this is the central sulcus. Just anterior to central sulcus we have primary motor area. Okay. Yes. Just anterior to that we have primary motor area. Anterior to the primary motor area is the premotor area, and behind that we have the primary somatosensory area, right? So for the pyramidal tracts, some 40-ish%. Okay, I don't remember the percentages. So most of the fibers are coming from the primary motor area, and that makes sense as well. Some fibers are coming from the premotor area, that also makes sense. And 40% of the fibers are coming from the primary somatosensory area. They are not sensory fibers, they are motor fibers, but they are coming from the somatosensory cortex. That is a paradoxical point, but you must remember this, that pyramidal tracts are originating in three areas of the cortex: primary motor cortex, premotor cortex, and primary somatosensory cortex. Right? I hope this point is clear. Now let's come back to our picture over there. Yes, I'm sorry. Now we are going to talk about the lesion in the premotor cortex. If there is lesion in the premotor cortex, there will be contralateral hypertonia and exaggerated deep tendon reflexes. Contralateral fanning of the lateral foretoes on eliciting the plantar reflex, that is positive Babinski sign, will be there because if the premotor cortex is gone, there is defect in the pyramidal tracts, and if pyramidal tracts are gone, so there will be upper motor neuron type of lesions which will be seen in the patient. Then frontal eye fields site, they are present posterior part of the middle frontal gyrus. If I show you in this picture, so this is the frontal eye fields. So these are the frontal eye fields, like over here. So these frontal eye fields, what is the location which they are telling? They are saying that the frontal eye fields are over there. Yes, frontal eye fields are present posterior part of the middle frontal gyrus. Function is the voluntary conjugate eye movement to the opposite side. Voluntary conjugate eye movement to the opposite side. For example, while reading the action of passing from end of the line to end, from one to the beginning of the action. So while reading the action of passing from end of one line to the beginning of the next, this movement is usually rapid, and it is termed as saccadic. So what is saccadic movement? Saccadic movements mean if you are reading a book and you are, suppose I'm drawing a line. So suppose your eyes were moving in this direction all the way till here, and then suddenly to read continuously and to read the first word of the next line, your eyes shift from this word to this word. This rapid shifting of eyes from one word to the next, from one line to the next line, this is called as a saccadic movement. Then the lesion, irritative lesion will attacks of conjugate eye deviation to the opposite side of the lesion, and destructive lesion both eyes are deviated to the same side of the lesion. So suppose this is the frontal eye field. If I draw this picture again, this is the frontal eye field. If there is an irritative lesion, a lesion that is irritating this field area, these are the push buttons of the eyes. When you press on these buttons, they will push your eyes to the opposite side, right? When these are getting irritated, they are getting overstimulated, and if they are overstimulated, they will cause conjugate eye movement to the opposite side, right? But if they are destroyed, completely destroyed, then the opposite frontal eye field will become dominant, and the eyes will be shifted towards the side of vision. So you must remember this ipsilateral and contralateral concept. If it is an irritative lesion, eyes will be shifted away from the side of lesion. If it is destructive lesion, the eyes will be shifted towards the side of lesion. Now let's come back to the next point. That is about the Broca speech area. It is very important. Site, posterior part of the inferior frontal gyrus of the dominant hemisphere. It is very important that in most of the people, the left hemisphere is dominant. So posterior part of the inferior frontal gyrus of the dominant, the word dominant is very important. Here you can see that this is the Broca's area, this area over here, it is in the frontal lobe, and this is the Broca's area. So Broca's area function is speech production, the ability to produce the speech, the ability to articulate, the ability to speak the words which are being made in the brain. That is the function of Broca's area. Moves the muscle of speech, that is motor center of the speech. It makes the speech clear and fluent. It is responsible for all the communicative motor planning, that is lesion will lead to difficulty writing and singing. Lesions, destructive, will lead to expressive aphasia. It means that know what you want to say but you cannot express the speech. It means it is such a horrible situation that you know that what you want to speak. You can understand what people are telling you. You can listen to people. You can understand their words. You can understand what they are saying. You know what you want to say, but you cannot say that. This neither can you write that. So this is happening in the Broca's aphasia or expressive aphasia. You will be speaking short sentences, stutters and stops. Watch for the broken speech. Broca's area, if the Broca's area is destroyed, you will have a broken speech, stuttering and stop and start. The differential diagnosis of the Broca's aphasia is the Wernicke aphasia. It is located in the temporal lobe. So here you can see the Wernicke's area is present over here. The Wernicke's area is responsible for understanding of the speech, and the words which you want to speak are also found in the Wernicke's area. So Wernicke's area It is located in the temporal lobe in the left hemisphere, also the dominant hemisphere. Speech comprehension, not production. It understands the speech which others are saying and also let you know what you want to say. Distraction will lead to fluent aphasia, fluent but meaningless speech. Now you don't know what people are saying, you don't know what you want to say. Your Broca's area is intact, which means you can speak, but you don't know what to speak. So there will be excessive vocabulary in your excessive words will be coming out of your mouth with no sense at all. Watch the lack of stutters and start and stop, unlike the Broca's aphasia. Broca's aphasia, you will be speaking like, suppose if I ask you that what is your name, you will be saying like my is name is name Ahmad name is. So basically you will be having stuttering and stopping and you don't know what to say, right? I'm sorry, in stutters and stops and you know what to say, but you are unable to speak the words which you are willing to say. In contrast to that, if I'm talking about Wernicke's area damage, and if I ask you what is your name, you will say the light is very yellow and the door is lying on the ground and the ground is full of sun and stuff like that. So anything is coming out of your mouth that is not making any sense. Then another differential diagnosis is global aphasia. Both Broca's and Wernicke's areas of the left side are damaged. The patient is often mute, cannot follow the commands, can occur immediately following the stroke, usually occurs with extensive CNS damage. Right hemiparesis and right VG loss will also be present if we are talking about the global aphasia. Then there is another area that is called as the Exner's area, area 45. This is not very high yield. It is a site adjacent to the Broca's area in the dominant hemisphere. Its function is center of writing. Most of the time when the person have Broca's aphasia or the damage to the Broca's area, they have simultaneous damage to the Exner's area as well, and those people cannot write as well. Lesion will lead to agraphia. The patient cannot express his ideas in written words as well. Next is the prefrontal cortex. The prefrontal cortex is the anterior two-thirds of the frontal lobe. The function is higher center for the mentality, personality and behavior. Inhibition of the primitive reflexes which are present normally in the newborn. So the prefrontal cortex is the suppressing area. So when the prefrontal cortex is intact, your brain is, when the prefrontal area is intact, your brain is basically, you know what not to say, right? You know what not to do. It is a suppressing area. There are different type of behaviors that there are a lot of ideas that come to your mind which are not doable. So the prefrontal cortex is inhibiting those abnormal or not so social friendly behaviors that are coming in your mind, or the ideas which should not be practiced. The prefrontal cortex is inhibiting those ideas. But if there is a lesion, another point is primitive reflexes. There are a lot of reflexes that are present in the newborn, like the Moro reflex or maybe the Gallant reflex and stuff like that. Most of those reflexes are gone by 1 year of the life. If those reflexes reappear later in life, maybe after 2 years or maybe even in the adult person, if those reflexes are reappearing, it means that the person is having some lesion on the prefrontal cortex. The lesion's mentality, personality and behavioral changes, lack of attention and judgment, disinterest in people and surroundings, and lack of personal hygiene ending in dementia. Reappearing of the primitive reflexes. It is very important buzzword to be given in the question stem. They will tell you that there is some person like 14 to 15 years of age boy and he is having reappearance of the primitive reflexes. So then you know that the lesion is residing in the prefrontal cortex. The paracentral lobule site is medial surface of the superior frontal gyrus adjacent to foot and leg area. The function of the cortical inhibition of bladder and bowel voiding, and lesion will lead to incontinence of the urine and feces. So your cortex is responsible for control of the bladder and bowel voiding. So there is cortical inhibition of the bowel and bladder, and if the precentral lobule is gone, so then you have incontinence, and that incontinence is called the neurogenic bladder, and I guess that is urge incontinence. I think it is urge incontinence. I think it is urge incontinence, but we'll see that in the renal section, inshallah. Now let's move on to the parietal lobe. Primary somatosensory area. Site is post-central gyrus. Function: perception of the cortical sensation from the opposite side of the body, like in the motor area. The body is represented upside down. So if I am talking about the somatosensory area, the homunculus or the distribution of the body area in the primary somatosensory area is similar to that in the motor area, but the difference is that the motor area is concerned for the motor activity and sensory cortex is concerned mostly for the sensory activities. Lesions, irritative lesions. If there is irritative lesion of the somatosensory area, there will be contralateral sensory Jacksonian fits in the form of numbness or tingling with a focal onset of March course. So there will be same Jacksonian pattern of onset of the fits, but these fits will be different than they will not be motor in nature. These fits will be sensory in nature. That there will be numbness of your hand, and then that numbness will go to the face and maybe to the lower limb and stuff like that, or maybe there is some tingling sensation that is starting on the face and coming down to the hands and then lower limb. So there will be Jacksonian march pattern of the fits, but that Jacksonian march pattern of fits is now in the somatosensory area. It may be followed by the motor fit if the irritation extends to the adjacent motor area. Destructive lesion to the somatosensory area, contralateral cortical sensory loss will be there. What is angular gyrus? Angular gyrus, the site of the angular gyrus is the posterior inferior part of the parietal lobe. The function is, if in the dominant hemisphere, it is concerned with reading, that is recognition and recall of the letters and numbers, that is done by the angular gyrus. Lesion will lead to alexia. The person who could read before the lesion becomes unable to do so because he cannot understand the letters numbers which he sees. So alexia means that initially the person was educated person and he could read the descriptions and everything, and then he had a stroke or something, and then he comes to you and presented to the ER and stuff like that. Now the patient is not able to read. It means the lesion is housed in the angular gyrus. The next point is about the Baum's loop. It is very important. The Baum's loop and the Myers loop, there are two loops, and these two loops for the visual field are very important. We'll see them later on. But the Baum's loop, that is a part of the visual pathway. Damage will lead to quadrantanopic anopia. The Baum's loop lesion, parietal lobe, the lesion in the parietal lobe will lead to the lesion in the Baum's loop. There will be pi in the floor and parietal lobe damage. If there is damage to the Myers loop, there will be pi in the sky, and that lesion will look something like maybe this. If the lesion is like this, so that is the damage to the Myers loop, and the lesion is in the lower quadrant, that is called as the Baum's loop lesion. The next point is the damage to the right non-dominant parietal lobe, that is called as the spatial neglect. Contralateral left agnosia, the person will not be aware of the left side of the body. He will not know that there is a left side of the body as well. Can't perceive the objects in part of space. Despite the normal vision, somatic sensation is impaired, and failure to report or respond to the stimuli on the affected side, and that is very important. There is an important test that when person is asked to draw the clock, he will draw it like this: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I'm sorry. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. There will be an empty half of the clock, depending on which side there will be an empty left half. Most of the time it is empty left half because the right hemisphere is responsible for the spatial neglect. So most of the time when the person is having a lesion on the right side, the left there is left quadrant and left agnosia in these patients. Then what is temporal lobe? Primary auditory cortex. The primary auditory cortex is present in the temporal lobe. The site is superior temporal gyrus. This area is very high yield. Function is auditory sensory area. The lesion, irritative lesion will lead to auditory hallucinations, and destructive lesion will lead to slight hearing impairment, nerve deafness, as hearing is bilaterally represented. Auditory associative area, site adjacent to the area primary auditory cortex. Adjacent to the areas of the primary auditory cortex. Function is recognition and recall of sounds. Associative area. So remember, now when we are talking about special sensations like maybe hearing or maybe vision and stuff like that, so there will be an area that is primary auditory area that is responsible for hearing, for detection of sounds. Then there is an association area which detects what sounds are they. They basically check for the previous memory, and they recall the diction of the previously heard sounds, and they compare and contrast the newly heard sound with the previously heard sound. If you have heard the sound before, maybe the sound is of your mother or your father, if you know that sound, the primary association area will tell you that this sound is coming from mama, or maybe from papa, or maybe some tape recorder, stuff like that. So you will know it. That is the function of the primary association area. If the association area is damaged, there will be auditory agnosia. The patient hears but does not understand or recognize what he hears. He does not recognize the sound, and he does not recognize what is being said. He does not understand that. He knows that sound is coming, but he does not understand what is the meaning of that. Then we have Wernicke speech area. Wernicke speech area lesion will lead to Wernicke's aphasia, and we know that there is the Broca's area is intact. There will be fluent speech, but the person will not understand what others are saying, and he will not understand what he is saying. Uworld point, the middle cerebral artery supplies the Broca's area, superior division, and Wernicke's area by its inferior division. Okay, and for the Wernicke's area, there is a word that we say word salad is there. Like in a salad, there are multiple vegetables and fruits in the plate, but so same is the case in the Wernicke's aphasia, that there is multiple words and stuff like that, but none of it is making any sense. Then olfactory bulb. Olfactory bulb is destruction will lead to ipsilateral anosmia. Psychomotor epilepsy. Epilepsy is most of the time when we talk about epilepsy, the first thing that comes to the first picture that comes to mind is a jerking patient who is lying on the floor, right? That is motor epilepsy. But there is another variant of epilepsy that is called as psychomotor epilepsy, which is associated. Basically, epilepsy is overfiring of the neurons of the brain. Now, which area is overfiring will give us the type of symptoms of epilepsy. Like if it is firing in the motor area, so definitely we'll have a jerky patient. But if we have overfiring of the somatosensory area, or maybe the auditory area, or maybe the olfactory area or visual area, so we'll have different symptomatology depending on which area is being stimulated. So for the psychomotor epilepsy, the person will be having sights or sounds or smells that are not there. It can result from irritation of the olfactory bulb. If you are talking about smell, so they are coming from the irritation of olfactory bulb. Parts of the temporal lobe epilepsy, commonly with the HSV encephalitis. Remember this thing, that whenever we are housing the epilepsy or seizure in the temporal lobe, you must always suspect HSV encephalitis, because HSV, herpes simplex virus, is very familiar, very famous for affecting the temporal lobes. Rare olfactory groove meningiomas, about 10% of all the meningiomas, they cause anosmia as well. Okay, then we have Myers loop. So remember, a few slides back, a few minutes back, we were talking about the Bombs loop. In the Bombs loop, it is present in the parietal lobe, right? And if it is in the parietal lobe, we are having the pie on the floor. And in the Myers loop, we have a pie in the sky, right? I'm sorry, yep, pie in the sky. So Myers loop, it is a part of the visual pathway. The Myers loop, it is present in the temporal lobe. There we have a pie in the sky, and middle cerebral artery stroke and temporal lobe damage can cause Myers loop defects. And pie in the sky picture of the visual field. What is hippocampus? Hippocampus is very sensitive to hypoxic damage. The lesion will lead to anterograde amnesia. We cannot make new memories. The person will have memories from 30 years back, but he will not remember the thing that you just said him 2 minutes ago. So anterograde amnesia cannot make new memories, can be damaged by infarction in the hippocampal branches of the posterior cerebral arteries and anterior choroidal arteries. Then what is amygdala? Temporal lobe nuclei, part of the limbic system. Amygdala is part of the limbic system. Important in decision making and higher functions. There is a very important syndrome that is called Kluver-Bucy syndrome. Damage to the bilateral amygdala, temporal lobes. There will be hyperphagia, hyperorality, and hypersexuality. So basically, amygdala is a part of the limbic system, and limbic system is responsible for the reflex, for the primitive behaviors, which include sexual activity, which include speaking and stuff like that. So basically, the primitive reflexes, the desires, are being controlled by the limbic system, and that limbic system, if that is being damaged, or if there is a problem with that, the person can develop Kluver-Bucy syndrome. There is a damage to bilateral amygdala in the temporal lobes. The person will have hyperphagia, that will result in weight gain. He will have hyperorality, tendency to examine everything with the mouth. That is also a very primitive thing to do. Animals do this, right? And humans, or even the children, they put everything in their mouth, because that is the primitive area to examine everything with their mouth. And inappropriate sexual behavior, that is called hypersexuality. Atypical sexual behavior, mounting inanimate objects. So this is something. Now there is a catch. If they give you a question time in which they are telling you that there is a child, maybe 6 years of age, and he is becoming hypersexual, or he is having sexual behaviors, or he has knowledge of the sexual behavior which is not normal in that age, he is having knowledge of that stuff. So it can either be Kluver-Bucy syndrome, maybe he is having damage to the amygdala, or maybe there is a child abuse. Maybe there is, that child has been subjected to sexual abuse by some predator, and that is how the child knows about those sexual behaviors. So you must read the question stem very carefully. Then there will be visual agnosia, that is inability to recognize visually presented objects. And ultimately we have the rare complication. Again, it is a rare complication of HSV encephalitis, because the amygdala is present in the temporal lobe, and temporal lobes can be affected by the HSV encephalitis, HSV1 encephalitis. Then we have occipital lobe. Occipital lobe is visual sensory area. for the perception of visual images. Visual association area, again the concept is same. So this is the visual, suppose in the brain, this is the primary visual area. It is responsible for detection of light and telling you that you can see something, some object, some light source, some light source is over there. Then there is an association area which tells you what light source is actually there. What are you seeing? You can see something, but what actually is the thing that you are seeing? That may be a rose, maybe a horse, maybe a clock or something. So association area tells you what is the thing that you're looking at. Visual association area function is recognition and recall of the images. Center of reflex conjugate eye movements to opposite side while reading, following the words of a line one after the other. This movement is usually known as pursuit. So pursuit is the action of my eyes when I'm moving from this word to this word to this word to this word, all the way to the end of line. Then from when end of line, when I will then from this end of the line, if I want to move to this first word, that is saccadic movement. Again there is a pursuit movement and saccadic movement, pursuit movement, saccadic movement, pursuit movement, saccadic movement. So this is something that you need to understand. Then we have lesion to the visual areas result in if there is irritative lesion. You may have unformed visual hallucinations by sparks, lines, flashes, etc. This occurs, for example, in the aura of classic migraine or in epilepsy when the occipital lobe is involved in the epilepsy. The destructive lesions will result in cortical blindness, and there is a very beautiful pattern associated with that. It is called as homonymous hemianopsia with macular sparing, because the macular area, the macula is, if this is visual field, the central area with the precisest, with the most precise vision is called as the macula, and that area, if I draw a brain over here, like this, if this is the occipital primary visual area, so the area that is representing the macula of the retina has dual blood supply from the middle cerebral artery as well as the posterior cerebral artery. So posterior cerebral artery strokes often spare the macula, right? Because the macular area is also supplied by the middle cerebral artery. Visual agnosia. The patient sees, for example, a familiar face but does not recognize what he sees. Paralysis of reflex conjugate eye movements, and blood supply is coming from the posterior cerebral artery for the whole primary visual area. The blood supply is coming from the posterior cerebral artery. There is an exception that is called the macula. Macula is also getting the blood supply from the middle cerebral artery. Now this is something that we were talking about for so long, that there is upside down distribution of body on the somatosensory area and motor area, that is called as homunculus. So what is homunculus? Homunculus is the topographic representation of motor and sensory areas in the cerebral cortex. Distorted appearance is due to certain body regions being more richly innervated and thus having increased cortical representation. Now what is meaning of distorted appearance? Now here you can see a very small foot and a very large hand, and a very big face with a small forehead and an open mouth, and then you have a very small tongue and trachea and stuff like that. So it is because some areas like hand has very rich motor supply, and other areas like maybe tongue or trachea, they have a smaller distribution of the motor and sensory distribution of the cortex. That is why the homunculus is drawn like that. So remember the thing, that if I am drawing a brain like this, like it is a cut section of the brain like this, and I am drawing cerebral hemispheres. Anterior cerebral artery moves over here, and middle cerebral artery is present over here. So middle cerebral artery is supplying the areas which are present in this region, and anterior cerebral artery is supplying the areas in this particular region, right? And then there will be anastomos definitely, and there is watershed area. So we'll talk about those things later on, but for right now, remember that if the anterior spinal artery is present over here, so anterior spinal artery will be supplying the lower limbs, and if there is a stroke of the anterior spinal artery, you will have lower limb deficits. And the middle cerebral artery, is supplying all the lateral convexity of the cortices. Like this is the area of distribution of the middle cerebral artery. So middle cerebral artery is supplying the upper limb and face. You can see that this is upper limb, and here we have the face and stuff like that. So all of these areas are supplied by the middle cerebral artery. Then let's talk about the motor systems. The motor system consists of four main components: the pyramidal system, which are upper motor neurons; the extrapyramidal systems; then we have the cerebellar symptoms, and the lower motor neuron symptoms. We'll talk about all of them one by one. So the most important motor system is the pyramidal system, or the upper motor neurons. It originates in the primary motor area and the premotor area, and also to some extent from the somatosensory area, but for the simplicity purposes they are just telling you about the primary motor area and the premotor area. Terminates at the anterior horn cells of different levels of spinal cord. What are the anterior horn cells? If I draw spinal cord like this, and there is a butterfly inside the spinal cord and like this, so these are the anterior horn cells. The corticospinal tracts or the pyramidal tracts will come over here and they will terminate at this point, and from here we will have lower motor neurons coming outside. We will talk about them just now. So coming back to the picture, so it terminates in the anterior horn cells with different levels of spinal cord. It supplies the opposite side of the body. The extrapyramidal system, it originates from the center situated at various levels of CNS. So it originates from the center situated at various levels of CNS, mainly the basal ganglia. It controls the opposite side of the body. Then we have the cerebellar system. It is composed of neo, archi, and paleo-cerebellum. These are old classification of cerebellum, but they are still used. So neo, archi, and paleo-cerebellum, it coordinates the movement of the same side of the body. The one thing that you need to remember about cerebellum is that cerebellum is an ipsilateral system. Cerebellum always controls same side of the body, and whenever there is some lesion to the cerebellum, ipsilateral deficits will be observed. So same side of the body, and that is the only area with the same side of the body distribution. Otherwise, in most of the areas of the brain and most of the areas of central nervous system, you have distributive problems in the you have problems with the contralateral side of the body. But for the cerebellar lesions, the problem is on the ipsilateral side of the body. Then lower motor neuron, it is found of the anterior horn cells and the peripheral motor nerves. So basically the lower motor neurons are coming from the anterior horn cells, like suppose if I redraw the spinal cord with a butterfly inside. So the lower motor neurons are originating in the anterior horn cells, and then they become the peripheral nerves and then go all the way to the muscles and target organ. So these are the lower motor neuron cells which transmit the motor impulses to the voluntary muscles. So here you can see the pyramidal system supplies the opposite side of the body. They are originating in the cortex, right? The extrapyramidal system, they also supply the opposite side of the body. Extrapyramidal systems are the corticobulbar fibers, basically the fibers which are going to the brainstem and medulla and stuff like that, into the cranial nerves. Those are called the corticobulbar fibers or the extrapyramidal systems. Then we have the cerebellar system, which controls the same side of the body. It is very high yield, and ultimately we have lower motor neurons which go down to the muscles. Okay, so upper motor neurons versus lower motor neuron manifestation, they are most high yield point in the CNS, and you must never ever forget them. So in the upper motor neuron, we'll talk about them one by one. So let me zoom it in now. So in upper motor neuron type of lesions, there will be weakness, there will be no atrophy, no fasciculations, reflexes will be exaggerated, which means there will be hyperreflexia, tone will be increased, which means there will be hypertonia. Babinski sign will be positive. It means that when you scratch the plantar aspect of the foot will move upward. There will be dorsiflexion of the foot. That is not a normal response. Then there will be spastic paresis. Okay, then flaccid paralysis will not be seen, and clasp knife spasticity will be present. Coming back to this point, lower motor neuron lesions. Now in lower motor neuron lesions, we see the weakness, and that is more profound. Atrophy is also present. Fasciculations are also present. Reflexes are decreased. There is hypotonia, hyporeflexia, and also hypotonia. Tone is also decreased. Then Babinski sign is negative. It is not present. Spastic paralysis is not present. In contrast to spastic paralysis, in the lower motor neuron type of lesion, we have flaccid paralysis, and clasp knife spasticity will not be seen. Now let's see this point. They are saying that lower motor neurons, everything is lowered, like the muscle mass is decreased, muscle tone is decreased, reflexes are decreased, and downgoing toes will be seen. In upper motor neuron, everything goes up, that is tone goes up, deep tendon, reflexes and toes, everything is going up. Fasciculation is basically muscle twitching, and that is present in the lower motor neuron type of lesion. Why is there any fasciculation? Fasciculation means, let me check that. Yeah, fasciculation present in the lower motor neurons. So suppose it was a muscle that was supplied previously by a nerve fiber. There was a nerve fiber that used to supply this nerve fiber, and on this nerve fiber, on this skeletal muscle, we had some when this nerve fiber was supplying this muscle, so on this surface we had nicotinic receptors. You know that the nicotinic NM receptors present on the skeletal muscles, and those NM receptors are cholinergic receptors which allow the sodium to enter into the muscles, right? When the muscle is being supplied by the nerve, there is some distribution of the NM receptors on the surface of the skeletal muscle. If due to some reason there is no nerve fiber that is supplying this, that is there is some sort of lower motor neuron type of manifestation, or there is some lower motor neuron injury, the muscle detects as if there is no impulse coming, so they upregulate the expression of nicotinic receptor, and the number of nicotinic receptor increases. But for these nicotinic receptors to be stimulated, we need some nerve supply, and there is no nerve supply. So whenever we tap the muscle, whenever we touch the muscle, so the sodium which are present on the surface, because of that tapping action, starts moving inward, and when the sodium moves inward, the muscle start trembling, and that trembling movement of the muscle is called as fasciculation, and that fasciculation is seen in the lower motor neuron type of manifestation. You must never forget that the fasciculation is seen, muscle twitching is seen in the lower motor neuron type of manifestation, while clonus, that is a totally different thing, that is seen in the upper motor neuron type of manifestation, and positive Babinski sign is normal in the infants. Remember that as well. We'll continue with the decussation and everything in the next session. Until then, Allah Hafiz, fi amanillah, and take care.